So today's topic is lymphatic filariasis. This is very important for your upcoming examination. Kamal, can I have your attention please? So what are filarial nematodes? These are vector-borne parasites which reside in the lymphatic systems of our body, skin, subcutaneous tissue and rarely in the body cavities. The lymphatic filariasis reside in the lymphatics and they produce chronic obstruction and fibrosis of the lymphatics. They are mainly two species, the Wuchereria Bancrofti and Brugia malayi and Brugia timori. Most of the lymphatic filariasis is caused by Wuchereria Bancrofti. So we will be going into details of this Wuchereria Bancrofti only. The cutaneous and ocular filariasis are caused by Loa, Onchocerca volvulus and Manzanella species. They reside in the skin, subcutaneous tissues and some in the eyes and the serous cavities of the body, and they produce various cutaneous and ocular manifestations. So what are the cutaneous and ocular nematodes? Tamal, Saurabh, cutaneous or ocular filariasis gulo ki? Loa, Onchocerca volvulus and Manzanella species. These are asked in your viva. You have to learn this chart by heart for your viva. The differences between various filarial nematodes. The Wuchereria Bancrofti, they reside in the lymphatic tissues, and the Microfilariae reside in the blood, rarely in the hydrocele fluid and the chylous urine. They come to the blood at nocturnal night time and their vectors are the mosquito culex. Brugia malayi, they reside in the lymphatic tissue. The microfilariae is found in the blood. There are also microfilarial periodicity is nocturnal and vector is the Mansonia and the Anopheles mosquito. The filarial nematodes are viviparous in nature and exist in two morphological forms. So what are these morphological forms? Adult worm and the larva, they don't have any egg stage. The adult worm is slender and round, measuring 2 to 10 cm in length. Some adult filarial worms can survive for many years in the humans, causing chronic obstructive and inflammatory conditions, causing elephantiasis and hydrocele, a condition known as lymphatic filariasis. The filarial nematodes, when they reside inside our lymphatic system for a long duration, they produce obstruction due to the large increase in number, and they produce obstruction and inflammation of the local skin. This causes elephantiasis, where the lower limbs get swollen and inflamed and resembles the legs of an elephant. So that is why this is known as elephantiasis. And hydrocele, this produces a condition known as the lymphatic filariasis. The larva has 4 larval stages. The first stage larva is known as the Microfilarial, and the third stage larva or the filariform larva are infective form to man. They are non-pathogenic, but sometimes hypersensitive reaction can occur against the microfilarial antigen, resulting in tropical pulmonary eosinophilia. What is microfilarial periodicity? This is defined as the time when most of the microfilariae are found in the peripheral blood. The microfilariae generally reside in the pulmonary blood vessels and occasionally come to the peripheral blood at different times, like daytime or night time, depending on the species. The nocturnal periodicity, the peak microfilariae is found at night from 9 p.m. to 4 a.m. like the Wuchereria and Brugia. Diurnal microperiodicity is seen in throughout the day like in Loa, and subperiodic, they are present throughout, slight increase in the afternoon and the night. There is Wuchereria which is transmitted through the Aedes. So mainly the Wuchereria Bancrofti has a nocturnal periodicity and they are found in the blood at night from 9 p.m. to 4 a.m. Now coming on to the lymphatic filarial nematodes, this is mainly, as we discussed, is caused by Wuchereria Bancrofti in 90% of the cases, Brugia malayi in 10% of the cases and rarely by the Brugia timori. It is characterized by chronic obstruction and fibrosis of the lymphatics leading to lymphedema, hydrocele and elephantiasis. So, Saurabh, তাহলে filariasis এর জন্য কি হচ্ছে? লিম্ফ্যাটিক সিস্টেমে মাইক্রোফিলারিয়া থাকছে, ক্রনিক অবস্ট্রাকশন হয়ে ফাইব্রোসিস হয়ে যাচ্ছে লিম্ফ ভেসেলস গুলোর, লিম্ফ ইডিমা হচ্ছে, হাইড্রোসিল and swelling of the lower limbs producing elephantiasis. About 893 million people in 49 countries worldwide are at a risk of developing lymphatic filariasis. Southeast Asia accounts for the highest burden globally, followed by sub-Saharan Africa. So, filariasis is predominant mainly in the Southeast Asia, and globally 90% of this is caused by Wuchereria Bancrofti, and in India the ratio is 99.4% and 0.6%. So, we can see at almost 100% of the cases are caused by Wuchereria Bancrofti in India, and India accounts for 40% of the global burden of lymphatic filariasis. This is prevalent in 256 districts across the 16 states, affecting more than 23 million people. The highly endemic states are UP, Jharkhand, Bihar and West Bengal, which accounts for at least 2/3 of the cases of filariasis in India. Coming on to the Bancroftian filariasis, Wuchereria bancrofti, this is the most widely distributed filarial parasite of the humans, accounting for more than 90% cases of the lymphatic filariasis. This is named after the two scientists Wuchereria and Bancroft who connected to its discovery. Life cycle, এটা ভালো করে মনে রাখতে হবে. How do the man get infection? The man gets infection by the bite of the mosquito, transmitting the infective form, the L3 filariform larva, which is then being deposited into the skin. From there, the L3 larva migrates into the local lymph nodes, and there inside the local lymph nodes, they develop into adult worms. Adult worms are found in the lymphatic system. From there, the microfilariae are found in the peripheral blood. And when the mosquito bites the infected human beings, the mosquito are ingested, microfilariae are ingested by the mosquito, and L1 larva molts twice inside this mosquito to become this L3 larva infective form. Then again the man gets infected by the bite of this infected mosquito. Tissue alterations related to the migration of the live adult forms such as lymphatic dilatation and thickening of the blood vessels occur. This is related to antigen and the toxic metabolites released from the dead adult worm. And there is also secondary bacterial and fungal infections and the host inflammatory response to both the live and the dead parasite. As long as the worm remains viable, the lymphatic vessels, though damaged, still remains patent. But the death of the worms lead to enhanced granulomatous reaction and fibrosis of the lymph vessels. তাহলে কি হচ্ছে প্রথমে লাইভ ওয়ার্ম গুলো ঢুকছে আমাদের হিউম্যানের টিস্যুতে. This cause lymphatic dilatation and thickening of these vessel walls. Tissue alterations take place which is related to the antigens and the toxic metabolites from the dead adult worms. Due to this, secondary bacterial and fungal infections take place, and as long as these worms remain viable, the lymphatic vessels, though are damaged, they remain patent. But the death of the worms leads to granulomatous reaction, and finally, due to granulomatous reaction, fibrosis of the lymph vessels take place. প্রথমে তাহলে ডাইলিটেশন হচ্ছে, তারপর ডেড অ্যাডাল্ট ফর্মস এর জন্য রিঅ্যাকশন হয়, গ্রানুলোমাটাস রিঅ্যাকশন হচ্ছে, and fibrosis of the lymph vessels হচ্ছে. Then it is causing lymphatic obstruction. Lymphatic function is severely compromised. কোন জেন্ডারে বেশি এফেক্ট করে? This microfilariae increases with age, starts at 5 years and peaks at more than 30 years of age. Males are more commonly affected than the females. The hormonal factors in females may be attributed to their higher resistance to infection. So, it a peak কোন এজে পাওয়া যায়? At least of more than 30 years. Males are more commonly affected than the females, and the hormonal factors in females are attributed to the higher resistance to infection. Incubation period. The incubation period is about 8 to 16 months. The clinical manifestations can be categorized into lymphatic filariasis, tropical pulmonary eosinophilia and immune complex mediated manifestations. So, clinical features গুলো তিনটে ভাগে আমরা ডিভাইড করছি lymphatic filariasis এ. একটা হচ্ছে lymphatic filariasis, প্রথমটা হচ্ছে lymphatic filariasis, and due to microfilariae inside the pulmonary blood vessels, tropical pulmonary eosinophilia and occult filariasis. Occult কেন বলছি? এই সময়তে তুই filariae ব্লাডে পাবি না, they are residing inside the pulmonary vessels, and immune complex mediated manifestations. So, the three types are lymphatic filariasis, tropical pulmonary eosinophilia and immune complex mediated manifestations. The lymphatic filariasis passes through the 4 stages: endemic, normal. A lot of people in these affected districts are endemic in nature. They do not produce any symptoms. Asymptomatic microfilariae. Microfilariae can be seen in their blood, but they do not produce major symptoms. Acute filariasis, when there is acute adenolymphangitis of the vessels, and chronic filariasis. Filarial fever occurs. This is high grade fever, lymphatic inflammation, lymphangitis and lymphadenitis, and the lower extremities are more commonly affected than the upper limbs. Transient local edema and dermatolymphadenitis occurs. And in chronic filariasis, there is severe lymphatic obstruction and pedal edema, as you can see in this picture, hydrocele and elephantiasis. Due to excessive swelling and lymphatic obstruction in the lower limbs, there is swelling of the lower limbs resembling the lower limbs of an elephant, and so this is known as elephantiasis. Chronic funiculitis and epididymitis and chyluria, where there is chyle in the urine and the producing milky white urine. Tropical pulmonary eosinophilia. This is also called as occult filariasis. This represents a hypersensitivity reaction to the microfilariae antigen. The microfilariae are rapidly cleared from the bloodstream and filtered, lodged and disturbed in the lungs, initiating an allergic response. So, the tropical pulmonary eosinophilia ki, this is known as occult filariasis. Occult means the filaria will not be detected in the blood. So, this is known as occult filariasis. This occurs due to a hypersensitivity reaction to the microfilariae antigen. These microfilariae are rapidly cleared from the blood and they are lodged inside the lungs, where an allergic response takes place causing tropical pulmonary eosinophilia. Eosinophils are raised. Microfilariae are not detected in the peripheral blood. So, how to diagnosis of this filariasis? Diagnosis is done by demonstration of the microfilariae by thick or thin smear stained with Giemsa or quantitative Buffy coat examination. The blood is collected during the night hours or at daytime after DEC by diethyl carbamazepine provocation test. As we have seen, this microfilarial periodicity is at night, but it is difficult to collect the blood at night. So, what will we do? We will be doing give the patients a dose of diethyl carbamazepine, so that after 1 hour the microfilariae will be present in the blood. This is known as the DEC provocation test. And then demonstration of the microfilariae is done by thick or thin smear and it is stained by Giemsa stain. How to demonstrate this Wuchereria Bancrofti? The tail tip is pointed and free of nuclei, and Brugia malayi, the tail tip is blunt and nuclei are extended up to the tail tip. এইরকম দেখতে পাবো আমরা, ঠিক আছে? টেইলের টিপ অফ দি নিউক্লিয়াটা নেই, এরকম একটা whip like একটা structure. This is known as the microfilariae of the Wuchereria Bancrofti. If you come to our practical class, I will focus on this microfilariae for you and show this. This will be in your examination, in your spotting, okay? This microfilariae of Wuchereria Bancrofti. And like this occurs like this, a thick blood smear stained with Giemsa stain showing the microfilariae of Wuchereria Bancrofti. This is present inside in our lab. One slide is present, okay? And others, what are the other methods of diagnosis? We can do antigen detection. Circulating antigens of Wuchereria Bancrofti can be detected by using monoclonal antibodies against the OG433 and AD12 antigens by ELISA and immunochromatographic test. These are more sensitive than microscopy and can be detected in the daytime and can differentiate the current from the past infection, but not useful for detecting the Brugia infection. তাহলে antigen detection টেস্টে কিরকম ভাবে করব? This is done by using the monoclonal antibodies against কোন antigen, OG433 and AD12 antigen by ELISA and immunochromatographic test. এই advantage গুলো কি? This is more sensitive than microscopy. We can sometimes in microscopy we cannot find this microfilariae even if the patient has Wuchereria Bancrofti filariasis. This can more sensitive and can be detected in the daytime also and can differentiate the current from the past infection, but is not useful for detecting Brugia infection. In an endemic area, antibody detection tests are useful only for epidemiological purposes, as they cannot differentiate between active infection and prior exposure. flow-through assay is done, which detects the total IgG antibodies to recombinant filarial antigen. And the luciferase immunoprecipitation system, this detects the antibody against the using the Wuchereria Bancrofti WB123 antigen. Imaging methods like ultrasound, lymphantoscopy and X-ray is done, and molecular methods like PCR and real-time PCR is done. Now coming on to the treatment part. So what will be the treatment? Diethyl carbamazepine is the drug of choice for the treatment of filariasis. What is the dose? This is given at a dose of 6 mg per kg for 12 days. This can kill both the adult forms and the microfilariae, and adult forms are cleared slowly. The treatment of choice ki diethyl carbamazepine given at a dose of 6 mg per kg for 12 days. This can kill both the adult forms and the microfilariae. Other drugs are albendazole. This is given as 400 mg twice daily for 21 days. This has also demonstrated efficacy against both the adult forms and the microfilariae. And ivermectin, 0.4 mg per kg of single dose can kill the microfilariae but has no effect on the adult forms. So, both the diethyl carbamazepine and albendazole are efficacious against the adult forms or microfilariae, but ivermectin can kill only the microfilariae but not the adult forms. Other drugs are doxycycline. This is given to target the intracellular Wolbachia, and this has also shown significant microfilarial activity like the DEC. Penicillin is also given to prevent the secondary infections due to bacteria. How to prevent this? Vector control is done under this National Vector-Borne Disease Control Program and the Elimination of Lymphatic Filariasis program called the ELF. All these vector-borne diseases fall under one category of program like the National Vector-Borne Disease Control Program. The anti-larval measures, this is highly expensive, mainly restricted to the urban areas. Chemicals like mosquito larvicidal oil, pyrethrum based oil or organophosphorus larvicides like phenthine and temifos are used. And anti-adult measures, pyrethrum spray or DDT are not effective. The National Filariasis Control Program in India has been active since 1955. This was integrated with the National Vector-Borne Disease Control Program in 2006. And India has launched a campaign in 2015 for achieving filaria-free India named as Hathi Paw Mukt Bharat. Hathi Paw means Elephantiasis Mukt Bharat, aims at assisting the filariasis elimination program of India. For this, the WHO has recommended ID regimen, which is this regimen ivermectin plus diethyl carbamazepine plus albendazole. A triple drug regimen is given so that resistance to one drug is counteracted by the other drugs. So এখন তাহলে কি তিনটে ড্রাগ দেয়া হচ্ছে সৌরভ, তিনটে ড্রাগ দেয়া হচ্ছে সৌম্যদীপ, কি IDA regimen, ivermectin, diethyl carbamazepine or albendazole to prevent the resistance of any one specific group of drug. It is implemented in selected districts of India. This assessment is done by conducting a microfilarial survey by peripheral blood smear examination once a year and once a month prior to the next MJ drug regimen and transmission assessment survey. Now coming on to the second part of our discussion, Brugia and filariasis. This can come only as a short note because this doesn't occur regularly. But lymphatic filariasis can come due to in your long question. A question will come, a patient has come to you with the swelling of the lower limbs and milky white urine. Tale diagnosis ki hobe? Milky white urine is Chyluria. This is occurring due to presence of chyle in your urine due to lymphatic obstructions and swelling of the lower limbs. So diagnosis will be lymphatic filariasis and your question will be like this. Now coming on to the short note of Brugian filariasis. What is this? The Brugian malayi accounts for 10% of the lymphatic filariasis and was named after his discoverer Brugge in 1927. The life cycle of Brugia malaria also similar to the Wuchereria Bancrofti, except the vector is in this case is the Mansonia, main vector for the nocturnal strains, and Anopheles and Aedes mosquito can also transmit the infection. And Anopheles and Aedes, we know, are also responsible for another type of infection, Anopheles mosquito for the malaria, falciparum malaria, and Aedes for the dengue. The subperiodic strains are transmitted by the Coquelictidia and the Mansonia. Reservoir, humans are the main reservoir except for the subperiodic strains. of except for the subperiodic strains of Brugia malayi, where the monkeys, cats and dogs are the animal reservoirs. Clinical features are similar to Bancrofti filariasis, but what are the differential features? There are more frequent episodes of acute lymphangitis and adenitis occurs in the femoral lymph nodes, and filarial abscesses take place. Chronic manifestations are less frequent. So, in Brugia and malayi, chronic filariasis is less frequent. There are more frequent episodes of acute lymphangitis and adenitis, especially in the femoral lymph nodes. Genital involvement is not seen, and elephantiasis swelling is limited to the leg only below the knee. Chyluria does not occur in this case. তাহলে কি ডিফারেন্স গুলো হচ্ছে? এইখানে ক্রনিক ম্যানিফেস্টেশনস লেস ফ্রিকোয়েন্ট, জেনিটাল ইনভলভমেন্ট দেখতে পাবো না, এলিফ্যান্টিসিস শুধুমাত্র লেগস আর নিজ এর তলা থেকে ইনফেক্টেড, and chyluria will not occur. Detection is done in the detection of the microfilariae in the peripheral blood. This measures 220 micron long, covered by a sheath, nuclei at the large, overlapping and present throughout the body. ওইখানে ছিল টেইল টিপ অবধি ছিল না, এইখানে কিন্তু পুরো টেইলের টিপ অবধি কিন্তু আমরা নিউক্লিয়াই দেখতে পাবো। Microscopy, microfilariae is seen in the blood, detected by the peripheral blood smear and stained by the Jameson stain. Antibody detection tests are also done here, immunochromatographic tests for screening and ELISA for confirmation. The Brugia rapid test is used, where immunochromatographic test detecting the parasite-specific IgG4 antibodies against the recombinant BMR1 antigen of Brugia malayi is used, and BM4 ELISA employing the recombinant Brugia malayi antigen BM14 is available. There is no antigen detection method. Imaging USG can be employed, and molecular method PCR and RT-PCR can be used. Treatment is also same like the Bancrofti filariasis, and therapy should be started with a lower dose. Prevention is also same for the vector control like Bancrofti filariasis, and removal of the pistia plants are done, where the Mansonia are the main vectors. Timori hoche to limited to only the Timor Islands of southeastern Indonesia, transmitted by the Anopheles barbosototis. This is morphologically microfilariae similar to Brugia malayi, except this is longer and more nuclei at the tail region. Clinical features, lab diagnosis and treatment are all similar to that of Brugia malayi. Okay.